Hey guys, today is a special episode of Why Should I Trust You? We do special episodes every once in a while. Don't freak out. I know it's not Thursday. We have another conversation we did with the Make America Healthy Again movement and leaders in public health. Some of y'all may have listened to the first conversation we had. We did it again. What we learned surprised us. There were some really interesting things that came up in this conversation, and let's get to it. Okay, welcome to our special episode.
Welcome.
Yes.
I am Brenda Adhikari.
I am Tom Johnson.
I'm Maggie Bartlett.
And I'm Dr. Mark Abdumalik.
Okay, so Brenda and I are journalists. Maggie is a virologist, and Mark is a doctor and a medical reporter. This show, Why Should I Trust You, is all about the breakdown in trust in public health, medicine, science, and what are we going to do about it? Pretty easy task.
Yeah.
We're going to talk about it. We're going to
talk about it.
Force people to step out of their echo chambers and interact.
So, look, we brought together some grassroots leaders from the Make America Healthy Again movement, as well as some pretty big names in the public health movement. Is that a movement? It was a really eye-opening conversation. And I think, look, a lot of people have asked us, like, why are we doing this? And I'll just say off the top, these are two groups that we've been sort of told that, like, can't even be in the same room with each other. That's how much they disagree. You know, whether it's one side saying the other side is that they're all anti-vax folks, and the other side views them as sort of like the big kind of iron fist of government telling them what to do, or that they're captured by corporate influence. It's gotten to a point where we just can't really talk to each other. And so on a most basic level, Tom, I think we're just trying to prove that doesn't have to be the case.
Right. And we don't have blinders on. We know that this is a incredibly wrenching moment for public health, for government science, for science in general. The cutbacks are profound. The redirection that's occurring at HHS is profound. People are losing their jobs. Critical research is being cut. There is a full reorientation of what our goals are as a nation when it comes to health and how to spend our money and our taxpayer resources. So with all of that as the backdrop, we felt it's more important than ever to start a dialogue, to have a conversation, because if you just sit back and see what's occurring on X or what's occurring in media or social media writ large, you think that there is no room for agreement, no room for nuance, and that we just are warring parties that just simply don't see things the same way. There's definitely part of that, but this conversation, I think it's fair to say, surprised us.
From their side, the MAHA movement, they want to be heard. They know that these people have a lot of information. They know that they sort of speak the same language, but maybe not the same accent. They do want to hear what they have to say. And then from the public health side, the entire job of public health is to protect and improve the health of communities. And if, 50% of your community is believing, X, well, then you need to understand that in order to essentially do your job. These public health experts, they want to help.
For me, getting to be a fly on the wall during those conversations was so enlightening, was getting to see both sides say, oh, well, it would be really helpful if we could talk about this, and so it was such a fun dialogue to get to see.
Yeah, the current approach is not working. So we might as well try this, which is really just opening up a dialogue. And the more that we dig into this, the more you find people like these wonderful group from MAHA, Ohio. They are there to engage, and hear the nuances and to dig into these issues. That's an opening for public health. Like the days of just sort of decreeing, this is the policy, this is the approach, press conference over, those days are gone. Like social media has ripped this conversation open and people want more and more information. And if public health doesn't step forward and provide that, engage in the conversation, it's going to get filled by this, the void's going to be filled by social media. And some of that is good and some of that is horrible. So it seems like there's not much to lose now, and a whole lot to gain, even if there's just little incremental steps towards trust.
So look, I want to set up this conversation. We're going to just kind of let this conversation rip. It's about an hour and 25 minutes. I did some editing for clarity, for some redundancies, because Tom takes so long to say stuff. I had to cut the silences out. No, I'm just kidding. But it's the same groups from the last conversation. So from the MAHA, Ohio side, you've got Elizabeth Frost, who's a grassroots organizer. She worked for the Ohio for Kennedy campaign. I think all of them did. Mark Harris, he's a political organizer. He also works for MAHA, Ohio. Nancy Fuller, she's a mom. She used to work in sales. She has a son who's been diagnosed with autism, and that has really led her on a journey for answers. Daniel DeLuca is a bar owner, also works for MAHA, Ohio. Donald Wiggins, unfortunately, was not on that call. He's also with MAHA, Ohio, and he'll join us for following calls, of which there will be more. And on the public health side, you've got Megan Ranney, Dean of Yale School of Public Health, Craig Spencer, who is at Brown, and he is an ER doctor, as well as with Doctors Without Borders. Caitlin Jetelina, who's the founder and author of Your Local Epidemiologist, an incredible health communicator. Reed Tuckson, who is the director of the Coalition for Trust in Science and Health, and Dr. Paul Offit, who is an infectious disease pediatrician with the Children's Hospital of Philadelphia and a co-creator of the rotavirus vaccine. So just to set it up, we started off the conversation discussing a hearing that Secretary Kennedy did a few days ago in Washington, where he was asked to testify in front of the House Appropriations Committee and then the Senate Help Committee, where he was really just asked questions about the budget for HHS, and which of course led to all kinds of other conversations. And I'll say that from the MAHA group, I keep saying they're MAHA, Ohio, grassroots, but these are also considered leaders within the MAHA movement. They just, just that day had come back. They had driven through the night, coming back from a conference in Washington, D.C., which was attended by about 200 people. It was convened by members of Secretary Kennedy's MAHA team, where they talked about all kinds of things, kind of aligning around the agenda, the MAHA agenda. And they were invited as they're called leaders of the MAHA movement. Like, again, we're excited to play this for you. And then do send us any questions or comments you have at whyshoulditrustyou.net. But let's take a listen. Just off the top, I think this hearing my texts have been shooting off with different people. It's just really started a lot of conversations. So I thought, if it's okay, I might play clips from it. And basically the question I want is, what do you hear in this clip? How are you receiving this information? And I want to ask everyone that. I'm not just directing it to one group or the other. I'm going to start with a clip of Secretary Kennedy, I believe with Congressman Pocan, at the first hearing.
Trying to get to know you, there's some public things that make you somewhat of a conundrum to people like me, just trying to understand. One is on vaccines, and I don't want to ask you about all the specific theories on vaccines, but something that might be helpful is you've previously said you vaccinated your children. Just because I think this is a helpful answer, and this isn't a gotcha, I promise. If you had a child today, would you vaccinate that child for measles?
For measles, probably for measles. What I would say is my opinions about vaccines are irrelevant. I have directed Jay Bhattacharya.
Sure. No, like I said, I don't want to.
So that everybody can make that decision. But I don't want to seem like I'm being evasive.
Yeah.
But I don't think people should be taking medical advice from me.
Right. No, I got that. And I'm not asking you to give them medical advice, but would you vaccinate your child for measles?
If I answer that question directly, that it will seem like I'm giving advice to other people, and I don't want to be doing that. I want people to make.
But that's kind of your jurisdiction because CDC does give advice, right? I'm not trying to do it as a gotcha. It's just kind of.
What we're going to try to do is to lay out the pros and cons, the risks and benefits accurately as we understand them.
Okay.
With replicable studies.
Okay. Mark, tell me what you heard in that.
What I hear is him speaking from an executive position in a political role, or I guess more of an appointed political figure role, saying, look, I'm here to make the thing function, to bring the data forward, to bring this information to you. You still need to trust either the people who specialize in this or your doctor, I think is what he was trying to get at least. I don't know if it's directly in that clip or sometime around that conversation. It's about the relationship with your doctor and your own understanding. And then it's a returning to this conversation of individual choice, the ability for here's all the information, but at the end of the day, you as an individual need to make that choice. And I think what he's saying is what I would, framing the question as what would you do will give credence to people to think, okay, I'm going to mirror what he does. And what he doesn't want people to necessarily do is mirror his behavior without having their own informed understanding and their own position and a conversation they've developed with their own connections with health beyond him as this high-level executive over a large agency that covers, a wide range of things. But that's what I hear anyways. But again, I'm also probably primed to give him a lot of leadway just from who I am and what I've done. So.
Well, Caitlin, let me ask you, what did you hear?
Yeah, so just out of full transparency, Craig and I, after we heard that, put together a Google Doc of our thoughts, because we had a lot of thoughts around this. I think on its face, sure, right? We shouldn't be getting personal advice from politicians. He, doesn't need to diagnose what Craig said, like our itchy rash, or schedule a colonoscopy for us. And the previous 3 secretaries of health were also not medically trained. So I don't think I was really striked by that. But I do think that this idea that health is entirely an individual responsibility it kind of goes against everything that I've learned in public health, that context really matters. That yes, everyone needs to be empowered on an individual level, but also our public institutions also can provide really strong structure and strong scientific guidance. And I am concerned that we're hurtling towards a new normal where public health is framed as a personal burden and not necessarily a collective good. And so I guess that was my reaction. Craig, do you want to add on to that?
No, I think that's perfect. Mark, thanks for sharing your perspective. For me, it was exactly that, about where are we seating institutions for individual responsibility? And when I hear, Dr. Oz saying that it's your patriotic duty to be healthy, I think that resonates with a lot of people who feel patriotic, but there's a lot of people that just can't be healthy, right? They don't have access to good food. They don't have access to good medical care. And I worry about all the people that, I've seen die from infectious diseases that were otherwise healthy, despite what we've heard from other leaders. So I worry that we're placing a lot of this kind of responsibility on the individuals and ceding a lot of the responsibility from the institutions that I think we really need to do that collective action. And I've been trying to think about it. Is this what the difference is between, RFK Jr. saying maybe he would probably vaccinate his kid for measles, but the thing that he really wants is treatments. We need new treatments. And I think that's fine. That's reasonable. But vaccines are like a collective good. They protect you, but they also protect others. Treatments are all about the individual. A treatment is about your individual health. So I'd love actually to hear from you all as well. What do you think about this reframing? Do you see this as a reframing from institutions to individuals? And do you see a risk in us doing that as kind of like a public health establishment?
Go for it, Mark.
Yeah, I guess I would assume that it is probably better when you're working from a public health perspective, like you all, to think about this from a collective mindset. But I can tell you from the MAHA movement, and people who are interested in this and the people who are sympathetic to it, they very much want to reclaim their personal health decisions. So it's kind of like, I see what you're saying, and I'm not trying to discredit by any means that angle. That is an important perspective. But I think it's kind of the opposite is where the desire lies. People want to reclaim that kind of autonomy over their public health. And I don't see any reason why we can't have both, why we can't have good recommendations from the top that tell people what to do who are looking for that informed information, but also letting people make decisions for themselves, regardless of what the consensus may be saying. If they have a personal reason to push against that, I think there has to be some respect for that. So I think this is more of a talking past us type, or a talking past each other thing. I think we can have both. But I do think, at least from what I see from MAHA, they would probably not prefer the framing of, of pushing it onto them because they're asking for it. So when you say, just for the terminology you use, this kind of shifting it to the public as a burden, I think some people might feel that way, but at least people in the MAHA movement want that brought to them. They don't see that as a burden added to them. They see that as a right they should have.
Reed.
Mark, let me just sort of follow up there, you or any of the other folks. I think that because I think what you said is important, that we're talking sometimes past each other. So let's talk right to each other on this issue. I have had the responsibility multiple times in my life where I am publicly accountable for doing everything possible to save as many human lives as I possibly can. That then sometimes, Mark, so anytime that there is something where people can make individual choices and it only affects the individual, have at it. It's perfect. But when somebody, and I'm curious how you think about it, when an individual's behavior can kill someone else, then that's where we kind of get into the problem. So let's start thinking about how do we, and again, this is not something we're going to solve on a call like this, but how do we start thinking about an individual saying, I demand the right to do something that will hurt someone else, but you can't tell me not to do it because it's my choice? How do we start holding public officials accountable for dealing with those kinds of issues, even when you're trying to say, look, I don't want to get into your life, do what you need to do, but just please don't kill somebody else?
If I can just respond quickly, I guess, to that. I think this, again, coming from the political side of things, I think at the gun debate in this country, should firearms be readily accessible to people or not? Personally, I don't think so, but I'm also probably in the minority amongst the people I live around and here. So, and the same thing with the debate on reproductive rights or abortion or however you want to slice that. The whole thing comes down to, when we're dealing with these political issues that affect people in this way, where it's an individual choice that affects other people beyond the individual, what ends up happening is tension builds between institutions who try to put pressure on people to conform. I think the much better approach, again, is always the honey over vinegar type angle. Instead of pressuring people to do what you want them to, try to encourage them to understand why it's better. I think, and this comes to the vaccines, I'll point to that. I think most people in the MAHA movement, if they could really get past their distrust, like they had, they saw something change that made them believe that these are safe and effective in the way that we all hope they would be more than happy to protect the community through that. I don't think anybody wants to harm anybody else by their individual choice in the MAHA movement. But I think the argument here is when there's a trust breakdown and one side is saying you have to do this for everybody else, you use the term killing somebody. I understand what you meant. I don't think you meant that, but I don't think anybody wants someone in a position of authority or an institution to say your individual choice, making the choice for yourself, is complicit in hurting other people. And just saying that will lose so much ground. So again, I think the better angle to take this is, let's focus on the concerns raised by the people who aren't adopting this readily as the system is currently structured. So then we can bring those people in on the good faith side of trying to do this. Because I think everybody does want everyone to be healthy. I don't think anybody wants an immunocompromised person to struggle or put themselves at extra risk because of individual decision. But also, at the end of the day, it's something that's going into my body. It's my health decision. It's kind of hard to separate that personal effect versus the group effect. So I don't think we're going to find the solution here today, but I do think there are polite ways of doing this that build trust versus terms and terminology that push people away.
I appreciate that. Thank you.
Paul Offit.
Okay, so I completely agree with Kennedy that no one should take his advice. I'm down with that. This is why Brenda always worries about me being on this podcast. But I think that he's right when he says that it is a personal choice. It is a personal choice, with the exception of, in an outbreak situation, a choice not to get a vaccine for a highly transmissible disease is a choice for somebody else also. But let's just set that aside for a moment and say that you are making a decision for yourself or for your child. I mean, it's your decision. And so what it needs to be is it needs to be an informed decision. And that's the problem. I mean, that's where we get hung up. How do you get your information? And I'll give you, let's go back to like 1995. I remember when the chickenpox vaccine first came out. So that the chickenpox would every year in this country cause about 10,000 children to be hospitalized, primarily with things like necrotizing fasciitis, which is like that flesh-eating bacteria, or pneumonia or encephalitis. I mean, there are about 75 to 100 children who would die every year from chickenpox. I mean, it wasn't in the measles category, but nonetheless, it was a disease that caused hospitalization and death. And so the vaccine came out. It was very much underused for those first few years. And people would call me and they would say, I've done my research, I've decided not to get it. But what does it mean to do your research? And I think that's sort of at the heart of all this. I mean, what they often meant when they said that is they meant they looked on the internet and for the most part read other people's opinions about the vaccine. But if you really want to do your research, I'm trying to find a nice way. So if you really want to do your research on the chickenpox vaccine in 1995, you would have read the 300 papers that were published on chickenpox vaccine, which would have meant you have had to have some sort of background in virology or immunology or epidemiology or statistics, which not only do most people not have, I mean, most doctors actually don't have that. So what do? I mean, they look to advisory bodies, at least collectively have read those studies and evaluated them. But see, that doesn't work, because when you say that, you're saying, trust us, we're experts. And that is not something you could say in the 21st century that has any resonance. So that's the problem. I mean, I couldn't wait to get my children a chickenpox vaccine. I mean, my children were born in the sort of 91, 93. So the chicken and in their particular daycare center, chickenpox was starting to circulate. I couldn't wait to get them that vaccine because I wanted that virus, the attenuated virus, the vaccine virus, living in their nervous system, not the wild type virus, because the wild type virus is going to be much more likely to reactivate and cause shingles when they were older. And then they didn't get shingles. They come visit my grave and thank me. But that's the hang up. I mean, how do you get it? RFK Jr. gives advice all the time. He's saying, give vitamin A. Vitamin A, quote, it's almost miraculous. And while it clearly is a value for measles, while it's clearly a value in Africa and has been shown to be a value in Africa, in this country, the incidence of vitamin A deficiency is like 0.3%. So it's not going to have much of an impact here, or any, if at all. And people had hypervitaminosis A and were admitted to the hospital in Texas with bone pain and with liver damage. I mean, so he does give advice. Maybe he thinks people shouldn't follow his advice, but you can't give advice and then expect people not to follow. So to me, this is my central point, is that I think, how do you get your information? Who do you trust? And so I think there should be a podcast called Why Should I Trust You? I think that's what I'm boiling down to.
Great idea, Dr. Offit. Nancy, you have your hand up.
First, I just wanted to affirm what Paul said, that I agree wholeheartedly that, and we've talked about this even on the last conversation about communication. And I was sharing, previously how little good, needed communication ever filtered its way down to me. And the fact that there could be 300 studies that we should potentially synthesize to get to a real decision, a good decision about chickenpox, is outrageous, that's what we would have to figure out how to do. But then you get to the ultimate question of, who do I trust in my sources and where do I go for that information? So I believe in medical freedom and I believe in informed consent, but I also believe that we need good information. And I think there's a huge gap in having a way to have a consensus about what the public thinks is good information. Like, how do we get to that consensus when there's so many really different ways to look at these things? And just from my business background, I've seen studies go where they don't like the independent study, that it's not going to favor sales of a product they've got, so they do another independent study. And one expert will say one thing, the same guy on the other side will say something completely different. And I saw that and I witnessed that multiple times, not for vaccines, but for business sales of products. And I thought, wow, how is anybody supposed to trust anything we as a company say when there's two ways you could even look at this? So if we could even begin to reduce the void of this lack of communication of good science, I think we would be on the right road.
Nancy, can I just say one thing? I completely agree with you. I think that the cigarette industry, for example, would also publish their own papers, and they said it. The people who did it said it perfectly. Our job is to create doubt, right? To just make it confusing. So this person says this thing, the other person says the other thing, and it's confusing. You know, there's 8,000 papers published in the scientific and medical literature a day in this world, a day. I mean, and they follow, not surprisingly, a bell-shaped curve. Some papers are great, some papers are awful, most of them are less mediocre. You can find a paper that says anything, and I think that's confusing.
Megan.
I want to follow up on Nancy's kind of point and question around good information, just to share kind of from my perspective. In medicine and public health, we're constantly thinking about balancing risk and benefit. And kind of there's always this like, you know, it's like the scales of justice. And there's always this like, you know, how much data do we have in one direction or another? What is the value of, you know, if we act, if we don't act, there are risks and benefits on both sides. How do we kind of try to synthesize the data and judge it to make a decision about kind of what we act or don't act on? And what are the priorities? And there's going to be different risks and different benefits. Like there might be, and we talked about this a little in the last call, there might be, you know, physical, emotional, economic, right? There's all different kinds of risks and benefits to any health decision that we make. Those of us who have spent our careers in health, whether public health, medicine, kind of affiliated health sciences, we've spent our career in these kind of both learning kind of how to read literature, but also kind of deeply in these debates. I struggle with two things here. I struggle with how to get that information, Nancy, to you or to others. And we've set up systems to try to do that weighing and to try to make it publicly accessible and to try to minimize industry influence in the decision-making. And it's not perfect because nothing is, but we try really, really hard. And so how do we share how hard we're trying and then also make sure that information makes its way to you? But then also, how do we push back against the folks like the tobacco industry who are, or maybe like the company that you used to work for, Nancy, who are purposefully muddying the waters? And I will say here, I sometimes worry about some of the people that are talking about risks about vaccines, because they're pushing their own supplements and trying to make money. And so they have a motive for muddying the water. So so that's my kind of question to the group that I'd be interested in your thoughts about, because to me, the evidence around measles vaccine is super clear that it's, you know, really effective. And we have tons and tons of studies about safety on a worldwide basis. I'd love to learn how to communicate that better, because for me, in the middle of a measles outbreak, like there's nothing better to prevent measles than a measles vaccine. So that's my question.
Elizabeth.
The reason I raised my hand is I wanted to tag in on the subject of communicating some of these studies and research down to people in a way that it's not going to be perceived as take my word for it, trust me. And I know this is easier said than done. So I don't want to gloss over how much work I know this would be, but I'd love it if we could get to a place where it's normalized that, you know, researchers, doctors, scientists, virologists, people who have an area of expertise in that specific study could translate these things line by line for people in a way that you can actually compare, you know, okay, this is how they've translated this to me. And now if I go back and I look at this line that they're referencing, I can kind of see how that makes sense versus, you know, a summary that people, like someone who's not educated on how to read a scientific study is not going to be able to look at that study and verify that what you said was true, or that they would agree with that assessment. So I know that that would be a lot of work, but I think that that's something that maybe would be useful for us to brainstorm in future conversations.
There's one thing I just want to ask on that, Elizabeth, because I think this gets at a really fundamental point. Do you think that that is what is the crux of vaccine hesitation on the part of MAHA, that there's just not enough good information? Or is it that the information that exists is not trustworthy because it may be coming from industry, or it may be coming from credentialed institutions that you aren't trusting as much? I genuinely want to know.
Yeah. There's a lot to unpack there. And, it might vary from person to person to some degree as far as where their mistrust really was born. I also think, that there are, just in human nature, there's a difference in what it takes to convince, one person versus another. And so I think while a lot of people feel like the information that we have about vaccine safety is plenty and, it's convincing to them, there are other people that, based on their own personal experiences, just want a little bit more. And I think to that point, an area that's probably perpetuated mistrust is the reluctancy, at least the perceived reluctancy to just answer those questions in the way that people are asking for them to be answered. And I would certainly welcome input from our public health folks if you feel like there's an effort to do that that's just not getting through, because we've identified this huge communication barrier. So I don't want it to come across as if I'm suggesting that you aren't trying. But I guess there's kind of a question in there somewhere. But Mark, I see you raised your hand. Maybe you wanted to add to that.
I think the big thing for me is at the end of the day, as long as I know there's a profit incentive attached to anything in public health, I'm always going to have a degree of mistrust. That's not individuals. And to be fair, if it was structured under a nonprofit structure, that doesn't mean people don't get paid. That doesn't mean there aren't executives who get to make decisions that are in powers of authority that also get compensated for their work they do. But as long as the whole point is, how can we make, after we've paid everybody off, after we've covered the cost of research and development, but they still want more money on top? And that's what these pharmaceutical companies do. There's just no question about it. That's what every for-profit, publicly traded company does. And as long as that factor is in there, there will always be, no matter how much I trust every individual thing or any individual study, there's always going to be that nagging thing at me. So I think to some extent, what this comes down to is mitigating that level of distrust, because at some point you're not going to convince me until you completely flip the entire economic system of the country, which is not going to happen. So just going to let everybody know on that one. But no, I think working backwards from that, we can go and say, how do we build better communication channels? How do we show that this isn't a for-profit incentive? And when I speak to you guys, nothing about what you have indicated to me in our conversation has been a for-profit motive. So for me, that means there are people involved in this outside of you, probably investors, probably people who don't even have medical backgrounds, who want to see profit out of this, that muddy this whole water even more. So that's where my hesitancy is. I'm sure that other people in MAHA have other reasons to be hesitant that don't necessarily tie to a profit motive.
Paul Offit.
Yeah, I want to pick up on something Elizabeth said. Like, I think she got to the heart of this. Who are you trusting? I mean, you're trusting the data or you're trusting the person? And I'll give you background for myself. So my father was the head of a national sales force for men's shirts. So every year, all these people would come from all over the country that sold shirts, and he would teach them about selling. And these people were really convincing. I mean, they had these outsized personalities. They were just vibrant. And I thought, this will never be me. I mean, I'm never going to be able to, as they said at these meetings, you're not selling the product, you're selling yourself. And I thought, this can never be me. And that was the attraction of science for me, because science was, to me, a meritocracy. I mean, you would, if you had good data, you would be able to publish that in good scientific journals like Nature or Cell or Science or whatever. And if you were right, I mean, ultimately, you would get your grants and you would be able to continue to do work, and it had nothing to do with your personality. And we ultimately were able to create strains that became a vaccine that had nothing to do with my personality. And I really like that. But here you have, so for example, on the other hand, and where I saw this play out in real time and in a painful way was when I had to testify in front of Dan Burton's Office of Government Reform in the early 2000s. And I was on a panel with Colleen Boyle from the CDC. And on the other panel was Andrew Wakefield, right, who had published a paper in the Lancet claiming that the measles, mumps, rubella vaccine caused autism, which was a paper that was not supported by the evidence that he presented. And there were studies done looking at whether or not you were more likely to get autism if you got the MMR vaccine or not. So he represented that point of view. MMR causes autism. And then on the side, on my panel was Colleen Boyle from the CDC. And she was, like all scientists, very careful about what she said. She would never say MMR doesn't cause autism. She'd say all the evidence for us doesn't support this hypothesis. And I watched Dan Burton just lay into her. And because he said, so you can't tell me that it doesn't cause it, do you? And just because her personality was one of being very careful. Whereas on the other hand, Wakefield, attractive, well-spoken, British accent. I mean, he was compelling. So it's back to the men's shirts. I mean, he was able to convince people because he was a convincing person, not because of the data he had. And that's what you're always up against, I think, in this, is the data versus the person. And in a better world, a world in which we don't live, it would be the data that sold themselves, but nothing sells itself, sadly.
Caitlin, go for it.
Yeah, I just wanted to respond to Elizabeth that, well, first of all, it's really hard to know what the questions are without working with someone. And I don't know if you guys all know on this call, but Elizabeth was so kind to provide a lot of constructive feedback on a 12-question FAQ around routine vaccinations. And I learned a lot about that you did want line by line. And I got someone to write line by line behind 150 studies for you that we're integrating into that FAQ. And then you also asked me to add a last question around, like, if you can't get vaccinated for whatever reason, how else can you protect yourself? And I think that's really helpful. So one, we need your guys' help in how to better communicate too, because we don't know what we don't know. I think it also goes towards what you brought up, Mark, around making a profit. I mean, I own a little communication public health thing in this world, but like that takes a lot of time to translate line by line. And who pays for that and how is a huge question I need to figure out. I mean, right now it's crowdsourced, which is great and it's going forward, but like how we do that from a place of trust is really quite challenging, and we deserve to get our time paid for that as well. I think I don't even know if I have a question. Oh, I guess I do have a question. Is like, Elizabeth, like once we get this FAQ back to you with your constructive feedback integrated, is that the type of information that MAHA is really seeking to, like, I don't even know if it's like to change people's minds. Like, my purpose is not to persuade, but it's really just to equip people with evidence-based information that's understandable. Or do you think it's something more fundamental on why MAHA is vaccine hesitant, and that sort of time and resources really just isn't worth it? Like, where do we spend our time, I guess, in this communication ecosystem is my question.
Yeah, absolutely. So I 100% feel like the FAQ sheet is very helpful. And, as you'd communicated to me, like having this as an easy to understand resource as opposed to like I don't want to say propaganda because that has a negative implication, but like a persuasive piece. I think that goes a long way for people. And one of the things that I heard frequently in the MAHA conference that Mark and Danny and I just came back from. We're all a little sleepy, so I'm sorry. But we just came back from DC. We spent 10 hours at this conference listening to keynote speeches from subject matter experts and people who have had, chronic disease complications. And oftentimes, they felt like they were robbed of a choice by not maybe having all the access to the information. And then there were folks, former FDA officials, doctors, medical providers, who were very passionate about the concept of informed consent, which I really think is the ethos of the vaccine conversation for MAHA. It's not that people don't want everyone who wants a vaccine to have access to it, or that they don't want the population to be vaccinated in a way that protects us from the next pandemic. But they want to be informed and they want to consent. And, I think that was really the ethos of the conversation, even though I would say they spent probably 90% of the time talking about food, endocrine disruptors, things other than vaccines. But that being said, when I do hear the vaccine conversation come up, it's really about informed consent. And so I think what you're doing, Caitlin, is making that conscious effort to try to inform people. And I think that is incredibly valuable. People really appreciate that.
Okay. Wow. Lots of hands. Look at all that. The Zoom is lit up. Danny DeLuca, please.
So one thing I wanted to bring up that I keep hearing every time we talk, and that we keep hearing, is trying to understand the community that we're in, I think is like a big struggle of where everybody's at. I think on this call, we have good representation from both societies that I'm calling it my own term for it. I think there's the America first, and then there's the Americans first, which I'm going to explain what I mean by that. So I think a lot of people grew up on this call where they saw America as like the prime example for, positive stuff, for medical research, for all these kind of things, and they had more of a community mentality as far as you take care of your fellow American. That is your duty. That is how you protect each other. You protect your communities. You go as a group. You do things united. I think, unfortunately, there's also the Americans first policy that started kicking in with people. As before, during America First, you had communities, they would watch a TV show and everyone would watch the same thing and be able to communicate on that. Like Friends came out and everyone's like, oh, did you watch this episode? Great, and they had a way to communicate and a way to talk. But now, because of social media, it's all individualized. So now somebody's watching their own little echo chamber and they're talking to only their own people. And so they're only talking to their own people and they're not seeing what other people are saying or not seeing the other things. So I call that more of the Americans first, because they're looking at themselves as individual, as the community, versus America as a community. And I think a lot of that goes back to the education on how people are. Again, my undergrad's in socialized education, so I try to bring it back to schooling and education as much as possible. But I think the big problem is a lot of people with the America First group was taught this is the shining city on the hill. This is where you want to be. This is helping each other. This is what you want to do to better your Americans and better all this kind of stuff. And then the Americans First generations is America is bad. It is a bad place. They've done a lot of bad things, and it is your fault because you're not helping enough people. And that's not all the education, but that was part of things that people learned as they grew up. So it really forced people into their own little mini communities because they felt that they no longer can connect to everyone. And I think that that's an educational issue. And that's why we have all these trust issues right now, because your America First group trusted your CNNs and your Foxes and your NBCs and your establishment and doctors without any questions. I mean, me personally, I never questioned a vaccine my entire life until the COVID one. That was the only one I ever questioned, mostly just out of intrigue because it was a brand new thing, or not brand new, but I know that existed for a long time, that mRNA, I know it exists, but as far as how it was implemented, I guess, was a brand new implementation. So I was interested in studying that and learning about it. And so now after COVID, I think there was a big trust issue with the America First group, because they were told, you take this vaccine and you will, the elderly in your life will not get the disease. But that didn't turn out to be true for a lot of them. A lot of people took this vaccine, still got sick, still got people sick in their homes. And I think, I personally have always said, I think the terminology for COVID vaccine, I think it should have been stated differently. And I know this is kind of getting into heated topic, but I think COVID vaccine should have been like COVID vaccine asterisk immunobooster or something along that line. That way it wasn't just straight up a vaccine, because when people heard polio vaccine, I got a polio vaccine, I don't get polio. But with COVID, there was, I got the COVID vaccine, but I can still get COVID. And I think it confused a lot of people because they didn't, their idea of what a vaccine was I get this vaccine, I am not getting this virus. And that was just the basic American understanding. And then that broke a lot of people's trust when they took the vaccine, they took the boosters, and they still got COVID 6 or 7 times afterwards. And I think that was where you had your community group and your individual group kind of start communicating, I guess, do we trust anything? I think that's where it kind of came along. I think that's where you had a lot of issues, was that. And I'm not, I got a vaccine, but I still got sick. And then the other people going, what's even in this vaccine? And then you just had these two groups collide. And now we're stuck in like, what is happening in this country? So I think it kind of, that helped deteriorate a lot of like questioning all the society. And a lot of that had a lot to do with that. Plus locking people in for 3 months where all they had were their own echo chambers to constantly reaffirm their own ideologies and not be able to talk to anybody else definitely didn't help the situation. So sorry for that.
Brenda, do you mind? Could I respond to that one thing?
Yeah.
Yes.
I completely agree with you. I think, this COVID, like influenza, like respiratory syncytial virus, like rotavirus, is a short incubation period mucosal infection. By incubation period, I mean the time when you're exposed to when you develop symptoms. You're never going to have long-lived protection after either a vaccine or natural infection against mild or moderate infection. But you will have fairly long-lived protection against severe disease, meaning keep you out of the hospital. It's when you mentioned polio, see, polio is a long incubation period disease, meaning from the time when you're exposed to the time that you develop paralysis is often weeks. So you don't need antibodies in your circulation anymore. You just need memory cells, which are generally long-lived and sometimes forever. So for long incubation period diseases like measles, you can eliminate measles from the country, which we did in 2000. Rubella, German measles, eliminated by 2005. Polio, eliminated by 1979. Smallpox, eliminated around the same time from the world by 1980. Those are long incubation period diseases. And I completely agree. Even in December 2020, when we were talking about this, when those data were presented to our committee, the FDA Vaccine Advisory Committee, in December of 2020, there was 95% protection against mild to moderate disease for both of those vaccines. And the reason is they were 3-month trials. Those people had just gotten their second dose. That's why it is that it was so high. You knew that wasn't going to last. And very early, we should have made that very clear, what this vaccine can and can't do, because you're right. People got that vaccine, and worse, they were mandated to get the vaccine, or they were fired from their jobs if they didn't get that vaccine. And yet still they would get moderate infection, which is not trivial. I mean, you may be home for a couple of days with fever and coughing and feel terrible. You're right. We should have explained that much better, and that hurt us. I agree.
I just have a quick thing for Daniel.
Yeah.
Like when you look at these little boxes and see the public health faces, do you think you're looking at people who are still living in the America first world when we're actually operating in an Americans first world?
I think that they grew up that way. And I think that mentality, and I think that's the better way to be. I definitely think caring about your neighbor and caring about your community is how we should be. I don't think this individual being locked in a box and saying, this is my ideology and I don't care what anybody else says is the wrong way to do it. I mean, I think that, we definitely have a lot of America First people, and we have some Americans First people on this phone call. I can see that for sure. And, I definitely am more of a proponent of America First as far as in my terminology, not whatever the political terminology is.
I know, I was going to say, it's kind of a thing now.
Right,
Danny.
yeah. In my personal explanation, not the national explanation, but what I used in this video for everyone to be clear.
So Megan, I know you still have a question.
Okay. I have a question for the group. Elizabeth, I really appreciated the point around translating the studies line by line, and obviously kind of the work that we're doing with Caitlin and kind of her point about who pays for it. I appreciate the stuff around informed consent. When I go and I buy a car or a TV or a new pair of sneakers, like I go and I do my research, right? Like I go on the internet and I read about it and I try to look at various kind of safety ratings and I compare versus various websites. But ultimately, I don't necessarily want to read kind of all the details about the engines or about the inside of the air conditioner, or right, like there may be various things that we all index on, but like I don't have the expertise to go into that level of detail. And honestly, it's too much information because I'm also trying to work my job. I'm trying to take care of my kids. I'm trying to be a decent spouse. I'm trying to see my family, my parents, right? There's a lot, maybe occasionally like sleep or exercise, like there's a lot of other stuff on my plate besides making those decisions. And I think as we're talking about this, one of the things that I'm kind of keep coming up against is not only who does this work of kind of annotating the studies line by line, but also do we really like, maybe that's necessary for the short term because of Danny's articulation of like the degree to which we've lost the trust. But is that like really what people want to spend their time doing, is reading through kind of the annotations and trying to, I think that's part of where I struggle. Like, again, if I use the car analogy, which isn't a perfect one, like I'll go to Consumer Reports. Like I would trust them over most of the other random websites out there when I Google it, because they're to me like a site that kind of compares the various things and tells me safety versus noise versus gas mileage. Like, I think that's what I struggle with when I hear your idea, Elizabeth, is that like, that's a lot of work to put on the individual if they even kind of have the capacity and if they even have a, like, I appreciate doctor informed consent, but a third of Americans don't have a primary care physician, including like my own doctor just left her practice. So like, right, like there's, so then who do you go to? And that's where I really struggle with this framing.
Well, Nancy, I wonder, because I saw you kind of shaking your head at some of the about whether that's what you're looking for. I wonder if you want to jump in and maybe say what is it that you're looking for, just to connect it to what Megan's saying.
For me personally, getting deep line item after line item would only really matter to me if I could trust the source. And Caitlin, I'm not saying I don't trust anything you're publishing, but what I am saying is we have such a struggle, it appears to me, within all of our agencies to come up with what people consider a trusted source. So I don't mind going deep if I know there's a consensus out there in my world and in my vantage point that says, this is a good one. Don't just go Google this, Nancy, on your own. Who knows what you'll get. But this Caitlin file is to be trusted, and pediatricians should be supporting it. And, you know, all kinds of people in our agencies should be all aligned. So the question becomes, we have misalignment. So I don't mind going deep when I know I've got a trusted source, but right now it's really hard to know who to trust.
Why do you think there's misalignment inside our agencies?
You know, there's such a perpetuating divisiveness politically. And I think it's just, you're on one side or the other. We're polarized on just about every major topic. And what we're doing here and having this discussion is kind of beautiful in a way that we're trying to take the polarity and come somewhere closer to a center that we can have a dialogue. And this polarity is just so far out there that you're either right or wrong. You're either in my camp or you are not in my camp. And then as a mom and as a citizen, I have to choose, well, which camp is right? And then you don't even know if you're 100% right in your camp. So that's kind of my take on that.
Craig, what do you think about that?
Nancy, I really appreciate you sharing that, because I think I shared the last time we spoke. I have people in my family that are ardent MAGA. I have people in my family that are ardent MAHA, and they are not necessarily the same. My parents are, you know, the other day when Trump came out with this announcement on pharmaceutical prices, my dad texted me and said, if he does this, he will be the greatest president of our lifetime. Although I think he already says that and he already thinks that. But they're not particularly MAHA. My mom is like, I don't really like RFK Jr. And so I'm trying to figure out as well, I don't even know that it's the polarities. I think you might have like a tripartition, and I'm trying to figure out where different people are in different places. And one of the things that I heard from our last call was many of you say, like, there's MAGA and there's MAHA, and some people are both, and some people only are one of them. And I've been wondering, like, what does it mean for you as a movement with a lot of power and with a lot of kind of grassroots support to feel like, in a sense, a lot of your ambitions and a lot of your power have been overlapped with MAGA itself? So that's one question that I have. And I'd love to hear your thoughts on that. And, you know, what are the opportunities, but what are the risks of that? I also wanted to recognize, Elizabeth, I hope you realize from the inner bowels of academia, one of our biggest issues and the thing that we fret about all the time is how we translate from academia to Americans. And we know that we don't do it very well. And that's why we have people like Caitlin and people like Megan that are unbelievably important. So thank you for that feedback and for helping us with that. And to you, Danny, as well, your point on the COVID vaccine, Paul said it perfectly, but this is like what we all wrung our hands about in January, February, March, April, May of 2021, as I saw people in my emergency room who went from being everybody to disproportionately the unvaccinated who were very sick from COVID, but then trying to think about how we change messaging as things change. But my questions are hopefully pithy and maybe hopefully poignant. One is going back to something you mentioned, Nancy, about medical freedom. And I know that this is, you know, really important to the MAHA movement. My question is, like, How do you think about medical freedom, particularly when it means that some people might be left behind? When I go to work in the ER, I focus on the patient in front of me. When I think about public health, I think about the communities that we work in. And I think particularly about the most vulnerable. And I'm thinking about this particularly with respect to the op-ed that was written by RFK Jr. and others on Monday about work requirements for Medicaid. In our last call, Nancy, you talked about how important Medicaid was for you and your family. And we know that there's a big push for work requirements now. But we also know that a lot of research through KFF, through others, have shown that work requirements don't just, hurt the able-bodied. They hurt people that have lack of awareness of eligibility, that don't have digital access. We know that some people who have disabilities, particularly around mental health, don't qualify, are still considered able-bodied. So I'm curious about your thoughts on that. Like, where does medical freedom overlap with and maybe is in tension with kind of our public health goals, and what are the knock-on effects? And then lastly, to your point, Mark, I have been extremely critical of public investments fueling private profits in pharma for a very long time. If you look at CAR T therapies, if you look at hepatitis C treatments that are $84,000, other treatments that were built on NIH-funded research and passed along to private corporations, I've been upset about this in terms of access. And you alluded to the fact that maybe you can't trust pharma if there are sole profit incentives. And I ask this a bit tongue-in-cheek, but like out of pure curiosity, what differences do you see between the CDC and the FDA and their role in vaccine oversight and the FAA, for example, and its oversight of air travel? Because airlines are first and foremost a profit-driven enterprise. They're extremely highly regulated. And every time we get on one, we depend on them for our life. But now we see that they've been weakened and people are actually dying. I'm in New York and a bunch of people that I'm talking to changed their flights to not fly into Newark because of what happened in a couple of days. So I'm curious how you're seeing, like, you got on a plane and you trust the FAA to do that work, but then there's other government agencies that are overseeing, kind of a similar profit-driven enterprise. Like, what do you see the difference between those two? I'm just generally curious. Thank you.
I do think when it comes to this health stuff, it is that same kind of quality. It is so intensive. It is so personal. And to some people, it is so very scary that just trying to trust and put this trust into anybody's hands, regardless of their own, there's resistance. So when it comes to like managing those things, I think there's always going to be like a core group of people who, no matter how much you do outreach to, no matter how much you say, no matter what you do, they're just going to be afraid. And I think as citizens of this country, if they are afraid for whatever reason, data or no data, there should be ability for them to choose to say no. I think the same thing on a lot of things. I think this is a country where, for better or for worse, freedom as a viewpoint on what you should be able to do, regardless of state intervention or what is better for the grander society, is a huge part of our cultural identity. In some cases, like what Danny was saying, I think it's gotten worse. In other cases, I think it's stayed the same a lot of history. I mean, the whole point of us was you can go out west and do it yourself until we ran out of west to go to, and you can't go do it. You can't go homestead and create your own community anymore. But back to the profit incentive thing, I wish we could have talked about it a little bit sooner before Caitlin had to leave. But I like her with her business and that having a profit incentive of feeding her kids, taking care of her family while she does the work she cares about. That's not a problem. I'm not upset about that. The problem is, and I think you pointed to it, Craig, was the private investment. The fact that there are people who have no clue about the industry, don't care about the people affected by it, and then they're just there investing and demanding they get their money back or more profit from it, not just their money back, but make a significant amount. Recently, I think it was between this call and the last call, there was headlines about United Healthcare being sued by some investors because they were going out of their way post the big event that happened with that we all can remember from earlier this year. Then they were trying to address more claims, make it a little easier just for a PR perspective in a situation that was very damaging. But they are now being sued by investors who don't care that the company is under scrutiny right now, don't care that there's a real public outcry and concern about them. And then they were trying to address it for either right reasons or wrong reasons, PR, or because they finally care, whatever you want to describe their reasoning. They don't care about that. They simply say, hey, we're not making the same amount of profits we were the last time, or you're not meeting our projections, and because you're making these other decisions and you didn't just consult us and our only position is make more money, we're going to sue you to try to get more money. Those type people, I think across the board in society, are leeches on society. Like whether it's medical stuff, whether it's planes and trying to cut the cost on plane maintenance, whether it's cars, any segment of the economy, the people that are just there to line their pocket more and more every day, those are the problem.
Elizabeth, do you mind if I just ask Mark a quick follow-up? Would you object? Okay. Mark, that last set of comments are important. I at some point, maybe in other conversations, we can dive into that. I do happen to have a pretty inside perspective on some of the things that you mentioned, and it's a little more nuanced, perhaps, than we can do a service to right now. The question I have really, though, is back to something else that's really important. And as you mentioned earlier, the notion of the concern about for-profit, and now you've touched it again. In the conversations that I'm in, a lot of those conversations are concerning because RFK Jr. also has a lot of for-profit work that he's done in this space, and many of the other MAHA folk have also done that. What's the difference, and how do I have a conversation with those who are very worried about his for-profit incentives versus others? Help me how do I sort of scale that out?
Yeah, I definitely see what you're saying. And I think on some level that there's a real concern there that I can empathize with. I guess just purely off of my understanding, most people see Kennedy as an ideologue to some extent. He believes it in a passionate level. He's not there. Profit isn't the main driver. It's just something secondary. And I don't think that's necessarily something everybody's going to agree with. And I don't necessarily think that is maybe even 1,000% correct. I'm sure that he enjoys his affluent lifestyle as much as anybody at that level does. And I'm not trying to say anything negative about people with money if they're not doing something negative to harm others. So, there's a bit of a nuance here, but I guess to answer it most directly, it comes down to an interpretation by individuals. And for whatever reason, maybe it's to what Paul was saying, his personality, his ability to be a politician, people don't read him as someone who is doing this for a profit incentive. I do think there are reasons to question that. And I do think that we should openly question that when it comes up, no matter how much we trust the individual or how much we like the individual. If they have a profit incentive or they're getting paid in some way, I think there's always room to question on those lines, no matter what level of trust we are with the individual. I will say in the difference that I'm seeing, though, why I think people maybe sound like they're talking out of both sides of their mouth on this is because at the end of the day, some people trust him, some people don't. And people who trust him don't think the profit incentive is the main driver. And people who maybe don't think it is a larger driver in his decision making. And I think that's more of an individual interpretation than it is necessarily a hard truth or anything like that. But I do think, and I would, if I was Kennedy, I would do everything I can to not get paid in this situation, because that only muddies your messaging and what you're doing. But life's life. That's people make decisions. I didn't like when he decided to join MAGA. I think that came up something earlier, a good or bad versus the MAGA attachment. Maybe that was Craig. I think the same thing. I would make different decisions, but I'm also not him. I also would do a lot of things different. I think the MAGA does come with a negative connotation in a lot of ways, but also what I saw on this event that came from yesterday, there were people talking about labor rights in the context of the MAHA movement that then just turned around and thanked Trump. So welcome to the world. Welcome to the segment of the political world where we have people praising Donald Trump for actions that align with pro-worker mentality. So I'm just saying things are shifting. There are very nuanced positions and people are very much in flux. So I think as long as we keep going with this and we can build layers of trust, I think we can get to a point where we can trust a lot of the recommendations and science behind things, and then we can still have room to disagree on some things, maybe like and dislike particular figures, but we can still get to a productive side on the other side. And I don't think we should see people as being inherently two-faced because they sound like that on initial interpretation, because I don't think most people mean in their own mind they've reconciled their position. Most people aren't switching between masks every day. Most people are just themselves, and they have rationalized their belief in their day-to-day lives by whatever means, whether that's a good thing, bad thing, neutral thing. I just think to get back to that point, this is a very nuanced thing, and it's very much in flux movement.
The one question that you all asked, and frankly I've seen asked from many people within MAHA and just skeptics in general, is the idea of working with a pharmaceutical company to make a product for the public good, whether it's a vaccine or it's a statin or it's a chemotherapy drug. I think the thing that is always so tough, right, when you're working with a pharmaceutical company is it's very different than a toy company or making Skittles or whatever, which is that these are things that save our lives. And I wonder, and maybe I'll ask this on the behalf of MAHA, and tell me if I'm getting this right, guys, but Paul, you've been in the room where it happens. And what is that experience like? Just kind of walk us through, working as a scientist with a pharmaceutical company to get a potentially life-saving product made.
Okay, so me and my two coworkers worked for about 10 years trying to understand various selected aspects about this virus, rotavirus, which in the United States causes fever, vomiting, diarrhea in children less than 2. In this country, it accounted for about 70 to 75,000 hospitalizations because of severe dehydration and between 20 to 60 deaths. But I did see a child die of rotavirus when I was a first-year resident at Children's in Pittsburgh, and it always stayed with me, and you'll appreciate this, Megan, especially in Craig. But so here was a 9-month-old girl, comes the sort of Appalachian mom I trained at Children's in Pittsburgh, salt of the earth mom, brings her child in with severe dehydration, brought back into the treatment room, and we couldn't get an IV into either arm or leg because she was that clamped down. So we called a surgeon to come down and to put a line essentially into the neck, which we weren't comfortable doing. But in the meantime, we did something I have never seen before or since, which is clysis, which is basically we took a bone marrow needle, sort of drilled it into the upper part of the lower leg and the tibia to try and get fluid to go into that space, so hopefully it would be absorbed to save her life. And then her heart stopped. And so we tried to resuscitate her and couldn't. And so then I had to go, because I was the youngest person there, but I had to go out then into the waiting room and sit next to a mother and tell her that her child, who was previously healthy 2 days earlier, her little 9-month-old girl, had died of this virus. And that always sticks with you. I mean, that's always in your head. But when I came to join Children's Hospital of Philadelphia, and they had a team working on rotavirus, had just started the year before, that was always in my head. But when you work there, you never think you're making a vaccine. That would be ridiculous. You're just trying to understand the virus. It came to be that over 10 years, we were able to create strains that we thought could be a vaccine. So then we went to all 4 major pharmaceutical companies that made vaccines. And a couple of things struck me at that point. One is they weren't going to make it unless this was something they could sell in the United States or in the developed world, period. It didn't matter how important it was. They weren't going to make a Zika vaccine. They weren't going to make an Ebola vaccine. They weren't necessarily going to make a malaria vaccine because that was not going to be profitable for them. And I should say, by the way, I think that you should be skeptical of any for-profit industry. I think that, and I'm including, by the way, in the alternative medicine industry and the functional medicine industry also, I think you should be skeptical, but you shouldn't be cynical. I mean, I think that although clearly pharmaceutical companies have acted aggressively and ethically and illegally at times, I mean, the opioid epidemic is the worst example. That doesn't mean they all act badly all the time. I mean, so my experience was this. It was mostly with the scientists involved in sort of the bringing that forward through sort of phase 1, 2, and 3 trials. And I'll give you one example. This is a little bit of a pet peeve. It always bothers me a little bit when people say, look, parents think this, but doctors think this. Doctors are parents. I mean, we actually are also people too. In my case, grandparents. And the same thing with the pharmaceutical industry. I mean, they too are parents, and many of them choose to go into this industry because they can make a difference. And I'll give you one example. So there was a woman named Penny Heaton. She did an internal medicine pediatric residency at the University of Louisville, and then she went to work for the CDC. So she went to Kenya, where she saw children die of rotavirus, because rotavirus is the biggest killer of infants and young children in the world. There's about 500,000 children who die every year in the world. It is the biggest killer of infants and young children, 2,000 a day. So she sees children die of this disease because it's a rapidly dehydrating illness. The problem is it's not only fever and diarrhea, it's vomiting, and you can't rehydrate children that are vomiting. That's why the World Health Organization gave up their oral rehydration program. Only a vaccine was going to save these children. So then she sees this. So she comes back and she decides to work for Merck, which was making a vaccine. And she takes them through their phase 3 trial. So prospective, placebo-controlled, 72,000 infant study done over 4 years in 11 countries, probably cost $350 million to do that one clinical trial. And then she was at this is an image. I only wish I'd taken a video of this particular image. So now she's presenting the results of that study. The code is broken. Now you're going to see the data. And it was at Merck Upper Gwynedd in front of maybe 200 people, all industry people. And so she's showing a series of slides. The vaccine works, it's safe. And then she shows a picture of the world, a map of the world. And there's throughout the world, there's these black dots: Asia, Africa, Latin America, each dot representing 1,000 deaths. She said, now we have the technology to prevent that. And she shows the slide where all those black dots are gone. And then in front of 200 people at Merck, she puts her head down and weeps and can't stop. I only wish I had a picture of that, because I think that is an image no one has of a pharmaceutical company. But there are a lot of people who work there because they think because it's the only place where you're going to have the resources and expertise to make that kind of impact. Yeah. Then she went to Gates and then proceeded to get the vaccine into the rest of the world. And so that vaccine saves about 160,000 lives a year. But I guess my impressions were that they're only going to make it if it's profitable. And there was one other story which I probably shouldn't tell you, but will. When Merck had a celebration at the Constitution Center in Philadelphia, so me and my two co-inventors were there being celebrated at some level, and the head of Merck Research Labs came up to me and said, "Congratulations! Why couldn't you have made something we give every day?" I think about that. I mean, you're never going to compete. Vaccines will never compete with things like lipid-lowering agents, psychiatric drugs, neurological drugs. It's a fragile industry.
Elizabeth, if there's something you want to engage him on.
Yeah, well, I think the anecdote that you generously and with a degree of trust that we will very much respect kind of touched on one of the biggest questions that Mark and I have had, which is, has there been an interaction with the pharmaceutical industry, where they directly reference profit as a priority? And, I think that's to tag on to that. And I think there's a very real issue with they language in modern American politics, just broadly and generally saying they did this or they did that. Who's they? And I know that you all have been so kind to dig into some of the frustrations that MAHA may have had with the public health response to, chronic disease, COVID, things like that. But I want to take the time to say something that I hope that MAHA can do better going forward, which is doing better about being specific and distinguishing who they're really talking about when they're making critiques of the public health system, because sometimes I think people really are in their minds, they're talking about pharmaceutical lobbyists, board members of pharmaceutical companies, and they're not distinguishing who they're really directing that frustration at, or who they really feel has been corrupted along the process. And to me, I think that's very damaging, not just to the movement, but to dialogue in general, because blame is often placed in the wrong direction. So I wanted to make that point. And then, I think I would be amiss to not connect something that Danny had said about technology and social media playing such a huge role in this communication breakdown, because this is the first generation that has been susceptible to algorithms, right? This generation of not just Americans, but the world. The more time you spend watching one video, now you're going to have 17 videos come up, that next day. God forbid you comment on that video or you like that video. And now it's just perpetuating, an echo chamber into your feed. And so I think that that's where we're losing so much nuance in this conversation, is that, technology places such a strong emphasis on engagement rather than access to information. And then I guess the last thing I'll say while I have the floor is, Megan, to your point, about how much do people actually want access to this information, the line by line or the detailed reports. And I think it's less about the fact that people really want to have to go read that stuff. It's that they want it to be available when they do want to read it. Your analogy in terms of, a car, it's, no, you probably don't care about the engine specs when you're, buying a car, but maybe you do because maybe you had an engine fail while you were driving and it caused a car accident. And now you are particularly motivated to research specs on an engine or a transmission in a vehicle. And so, I think that it's not about expecting individuals to do all of this extra work. It's about exploring how do we improve systems and processes in public health dialogue in such a way that we're not asking individuals to spend an extra 26 hours of a 24-hour day trying to put this information together for us, but how do we work together to build a future where these things kind of happen organically? So that's what I had.
I have to leave in 1 second, so let me just say this. Thank you, Elizabeth. I think what would have been fairer at some level. I mean, I was funded for 26 years by the National Institutes of Health, which is to say I was funded by you. I mean, I was funded by the taxpayer. And it was the taxpayer that paid essentially for the creation of those strains that became the vaccine. Merck then spent probably $1.2 billion to do the research and development, but they, to some extent, do owe the taxpayer something for the fact that all that research was done outside of that industry. And I think that would be a place they could pay it forward a little more clearly.
I just want to jump in real quick before you leave. I know we've literally got a minute, but the thing that really would stick out to me, Paul, is so you see that you recognize those people are problematic, that they're asking for how can you not make this more profitable when you're saying for this section. How do we pressure those people to stop thinking about the profit and start caring more about the actual health of people? Not you guys, but them.
I think they do care about the health of people. I do. I mean, okay. Sitting next to Ed Skolnick, who was the head of Merck Research Labs at one moment, and it was GlaxoSmithKline had made a rotavirus vaccine that could have sort of clashed, not GlaxoSmithKline, Wyeth had made a vaccine that crashed and burned. And that meant that this next vaccine was going to be much more expensive to make because now you weren't going to do a 30,000 person trial, you're going to do a 70,000 person trial. So it was $10 million for each 1,000 people. It was bad. It was a very expensive vaccine to make. And I remember saying to him, are you still going to do this? And he said, yeah. So I said, why? He said, because we can. So I mean, we do have the technology to do these things, and there is a sense of responsibility. There is, but it is a for-profit industry. If they can't make a profit on it, they're not going to make it. So you have to find. I mean, the rotavirus vaccine could have been made in 3 years, not 26. It was 26 years to make that vaccine if we had an Operation Warp Speed. That was, because what Operation Warp Speed did is it took the risk out of it for pharmaceutical companies. The government paid for phase 1 trials, phase 2 trials, phase 3 trials, paid for the manufacturer, paid for making millions of doses. And if it didn't work, they wouldn't pay a penny for that. They would just throw it away, and that was that. They took the risk out of it. That's why it was so fast. So the degree to which the government can be involved in that could certainly make it much quicker. And but the companies would have to respond. And I feel that with Pfizer and Moderna, for the fact that Operation Warp Speed took the risk out of it completely for them, I think that they continue to make far more of a windfall profit, frankly, than was fair, given that the government that paid basically $11 billion to take the risk out of it for them. Come on, how about a little, in the words of J.D. Vance? Thank you.
Yeah. Can I add one quick thing quickly? I just dropped something into the chat. And honestly, with your relationships with MAHA leadership, I would be incredibly grateful if on this point, in terms of like thinking about equitable access, this was something that was passed in January 2025 to start on June 1st, 2025. It's an equitable access agreement that basically says if the NIH has put money into making these pharmaceuticals, there needs to be an access plan to make sure that certain communities are able to access these treatments. And so I think it is a place where we have incredible overlap. My concern is that this administration is not going to take this as seriously as the previous administration or previous kind of health leadership. But I would really appreciate it if you think about this, look at this, and then if this is something that you can support, elevating it to the right people, because this is incredibly important to do exactly what you, Mark, want to get done, what I want to get done, and ensure equitable access to all of these things that we pay for.
Megan Ranney, please.
Thank you. I just wanted to talk a little bit about the profit incentive. I'd like provide kind of my perspective on it. The first is that I can say on behalf of, I think, much of the public health ecosystem and kind of healthcare ecosystem, this is actually one of our huge frustrations, particularly when I look at some of the people who are kind of have become, in the same way that you look at kind of what we do and kind of say, oh my gosh, you guys are affiliated with pharmaceuticals. I look at some stuff and go, well, you're affiliated with people that are like pushing ineffective or harmful supplements and medications and making tons of money off of it in really unethical ways. America's Frontline Doctors is one big example from during the COVID pandemic, that they were basically pill mills of stuff that caused harm. And so that kind of monetary incentive is something that I do think is really, really important to talk about and for people to disclose. And I will say, for me, I'm part of like the Sunshine Act, where if I ever take money from a pharmaceutical company, I have to disclose it on this government database. And any paper I write, I have to disclose if like my family holds stocks. Right. And so, but also just to highlight that the current cuts that are happening, the like $2.7 billion in ongoing research studies that have been stopped, the $2.3 billion in money that was appropriated to NIH and to CDC that hasn't been spent, what that is doing to the scientific and public health infrastructure is that it means that people are turning to corporate partnerships, because otherwise the programs that we know are maintaining or promoting health are getting destroyed. We have no way to pay the salaries of PhD students. We have no way to pay for the science that can, lead to the next life-saving discovery. And so, ironically, the current kind of being against the profit motive is actually driving the profit motive more into partnership with academia than it has traditionally been, because we have depended on the federal government to be our partner. And now we can't anymore. And we care about science and we care about human health. And now we're being forced kind of into it. And again, it's not that I'm trying to demonize corporate interests, because to my second point, that is a huge part of the American story. I think we have to be eyes wide open. But
so research is being forced to now turn to the marketplace for help to develop these things rather than government.
That's right.
And let me give you just a quick sense of what it's like inside. I think one of the things that that was brilliant that Elizabeth said earlier, and that was the word "they." I think that there needs to be great carefulness as to who the "they" are when you talk about the pharmaceutical world. Most everything that you see as a pharmaceutical product that you like came from small biotech companies. And I would tell you that I've been on enough of those. It's like 10, 12 years of jumping from ice flow to ice flow to get enough investment from people to keep the business alive. I've been on a bunch of them where you've had to lay off like everybody at the 11th after you're close to the finish line, and then you had to implode because you just couldn't get the capital to conclude. And so my point only to you is I think that "they" word is, if there is not any financial upside for the people that invest capital, there is no money to do the drug development to solve the problems we're talking about solving. So Elizabeth, thank you for the incredibly useful "they." And I think we just have to find a way to get. And by the way, I hope that also just one other little thing, because I live this world, and I have to say I'm fairly passionate about it. The people that are doing that research are people that are absolutely, totally committed. Their entire lives are committed to helping people. These are not people that are doing this work to make $1 zillion. They are doing the work because that's who they are. And it's terrible when there's not enough money. And finally, I do hope that as you all deal with your MAGA colleagues, what you are now seeing, if you don't know, if you don't understand, is the destruction of the American health research enterprise. It's being wiped out when you combine what happened at the NIH and CDC with the cutbacks to the universities. So all those university cutbacks, I can't tell you how many young people I am having to counsel and talk to who are parents of children who have been laid off from doing their research, who have nowhere to go, do not know how they're going to pay their health bill or their mortgage. This is a powerful moment, and we hope that you might be able to give voice to that as this conversation goes forward.
Thank you, Reed. Elizabeth.
Yes. Well, first, I want to say, Reed and Megan, I agree with every single word that you both have said. And I think that a lot of folks in the MAHA community feel the same way. And even comments that Secretary Kennedy made during the congressional hearing in terms of saying, I think out loud, probably for the first time at that scale, and I know a lot of people in the MAHA community were hungry for it, is to hear him create that separation between what he wanted and the DOJ cuts, and to say that, you know, of course, in his position, he doesn't feel like it's good for his objectives and for just public health in general to go through those cuts. Now, I think that there's probably, you know, a lot of difference and nuance maybe in what the correct approach was between the two, but I think there's very much, you know, a consensus and an agreement that, you know, we need to figure out what we can do to support these people who have so much knowledge and so much to give these, you know, questions that I think, you know, we're all asking about health and how can we become healthier. So very, very much aligned there. And I wanted to say that for sure. And I also think, you know, it is really challenging when we're dealing with the they type of dialogue to make sure that people are really digging deep enough. And something that you had touched on, Reed, is that a lot of these folks have no financial incentive, regardless, you know, of how this research turns out, and they're being lumped in to this, you know, cohort that's being accused of being corrupted. And I think it's so important that we work very consciously to incorporate that nuance so we can get to the root causes here.
Can I just real quick, Elizabeth, totally, I appreciated that separation in the testimony, but RFK Jr. did say that there had been no cuts to life-saving research during his hearing, which is not true. There have been lots of cuts to life-saving research. So I just...
Yeah, no, and I had caught that portion of the congressional hearing as well, and I believe like the specific language was that he said to the best of his knowledge, and in that moment I'm thinking, well, we need more knowledge. You know, we need more knowledge on this subject, and I'm hoping that, you know, saying those words out loud, like so often just, you know, as individuals, you know, when we hear ourselves say something out loud that maybe we haven't really put the appropriate amount of thought into, that was an eye-opening, you know, experience to dig into some of that deeper. But I caught that as well. And yes, I mean, 100%, I think that they're, you know, and I don't know truly as someone on the grassroots side, I don't know what a day as HHS secretary looks like. But I would certainly hope that this is something that he's going to be digging a lot deeper into going forward.
Mark, you want to jump in?
Yeah, to what Elizabeth was saying about, you know, the they conversation, the not lump people in. Yesterday at the event, not the same person, but amongst the panelists, there were people who spoke out against the cuts to Medicaid and Medicare. I thought that was very interesting. I'm sitting across from somebody wearing literally a dark MAGA hat, and the person who's speaking to us both, and we're both clapping for, is saying we don't need to cut those things. So I think there is more nuance on that side, that not everybody is the same on that. And to another point, it's not just, you know, the cuts and stuff too. So there was some regulation cut back on PFAS stuff that came down. And these people were saying, like, you know, this is a little bit beyond what we can currently do, but we can speak to it. Again, this is the organization, not Secretary Kennedy and his position locked into any space. So they were speaking against these things and talking about how damaging and detrimental they really are. So I think the movement goes beyond the limitations of the Health and Human Service Secretary. by being a mouthpiece for these issues. But at the same time, I think some things are limited to the space that they're in. I think that's one thing Kennedy pointed to. I think one of the senators with the Medicaid, Medicare was saying, "How is this good? How is this not going to hurt public health?" And he says, "Look, I can't make that decision. I'm in the executive branch. I'm under this. I can make recommendations. I can say these things, this, that, and the other. But the bill, the language they were pointing to, is coming from the House." I don't know if anybody knows about Republican House reps, but they aren't really beholden to anybody, even the party. So they kind of get a little bit out of line. And so I think this is politics to some extent. I think people say things because they're politically convenient. People got to cover their ass in politics. Forgive my frank language there, but and I think that sometimes can be miscued in a way that makes it feel like the ethos or the mentality that's being approached here is not one that we're trying to reach the best solution.
Hey, Mark, just to borrow a term that's come up a lot, do you think RFK is captured right now by MAGA and the Trump administration?
So I'm going to answer yes and no in this. I don't think ideologically he has captured himself personally. I think he still thinks for himself. I still think he makes decisions that he thinks himself is the best decision to make. But the captured part where I would say yes is he's very much locked into the boundaries of like he's on a leash, for lack of a better way to put it. If you go beyond that leash, he can buck the whole system and say this is terrible and call Trump out every day for the things he sees are wrong. He could go after the individual reps that are backing this bill. But that would actually probably in the long run hurt his position and his interests. So yes, in the fact that everyone in politics that has in a position of power, they're limited by what that power is supposed to be with that position, or at least we can still hope that the Constitution limits people's in their power what the position they're in. And then two, they're limited politically by what can be done. I forget who it is, the quote it should be attributed to, but politics is the art of the possible is the quote. It's not always what is the best. It is not always what should be done. It's what can get done and moves the ball in the direction that is found valuable by that individual or whoever. So I think keeping that in mind, both yes and no, he's captured. I don't think mentally he's captured. I don't think he himself has switched his ideology to align with them. I think he's just playing within the space that he has the ability to play within.
Okay, I'm going to give Elizabeth the final word, and then we'll wrap things up for this session. Elizabeth.
Yes, if I could, I just wanted to liken Mark's point and Tom's question to, I believe it was Paul who made the point earlier, that a lot of these researchers, they realize that Big Pharma is broken in many ways, but they also realize that in some ways it's the only way that they're going to have access to the resources and the platform to actually make a difference on these issues. And so just as a little thought experiment, maybe we can kind of try to frame some of that, the conversation around, if RFK is captured in the same context of like, this is what it took for him to be in any position to enact change. And that comes with a leash, unfortunately. I think most of us on the MAHA side on this call, or actually all of us on the MAHA side in this call, were involved in, the campaign, and we wanted it to be him. We certainly, Trump was not our first choice, but I think, to some degree there is a comparison to be drawn between, just two very different ideological groups, perhaps, that are just trying to work and do what they can within a system that they recognize is broken.
Okay, well, listen, that was our episode. We hope you found that conversation interesting. I think there were so many things that came up. I know that that I'm going to reflect on these groups. As much of an impasse as there is, I'm always kind of stunned by where they see the same things.
Yeah, I was struck just along those lines about how people are feeling we're using the term "they" too much. Like they think this, they do this, and when you break it down, it's a bunch of individuals. They've got different points of view, and who knows where all this is going to go. But there's a lot more possibility here for bridges than I think is often you take away from if you're just sitting back and watching this play out in social media. Brenda reminds us at the top of these shows to to weigh in with your comments. This is a perfect one to weigh in. We want to hear from you. We have a lot of people who are sympathetic to the MAHA movement who listen, a lot of people who are sympathetic to the sort of traditional public health, infrastructure. We want to hear questions that you want surfaced in these conversations going forward. It's super helpful to get your insights. So please leave us comments.
Well, listen, thank you for listening, and we will be right back here on Thursday.